Onc Live Insights is a video editorial program produced by Onc Live.
Future directions in chemotherapy-induced nausea and vomiting, I anticipate to include some of our newer agents, which include rolapitant, newly approved NK1 receptor antagonist without CYP3A4 interactions and a longer half-life. I'm anticipating many more studies by Rudy Navari through the Alliance cooperative group looking at the use of olanzapine not only in prophylaxis but also in breakthrough and refractory nausea. I'm also anticipating that we're going to be exploring other indications, and one clear area that needs particular attention is in patients receiving multi-day chemotherapy, especially in hematologic malignancies, because currently our guidelines do not offer any clear direction on how to appropriately prophylax these patients. And of course, in hematologic malignancy, there's a lot of drug-drug interactions, and we would ideally like to spare them as many drugs and steroids as possible. I also am anticipating looking at protocols and building the literature around patient-specific risk factors and using patient-specific risk factors in combination with risk of chemotherapy in terms of how we prophylax patients. Data that has recently emerged from our international conferences include a Japanese study that was presented in ESMO this year looking at colorectal cancer patients who were receiving oxaliplatin. Oxaliplatin is considered moderately emetogenic chemotherapy. However, as a GI oncologist, I can tell you that there are lots of patients that still experience nausea even with appropriate prophylaxis, which would include a 5-HT3 receptor antagonist and steroid. So at ESMO this year, Nishimuro and colleagues looked at patients receiving oxaliplatin for colorectal cancer patients and compared standard prophylaxis with palonosetron and a steroid versus palonosetron and one of the currently available NK1 receptor antagonists, being a prepitant or fosaprepitant, in over 400 patients. And what they found was about a 15% reduction in emesis for their primary endpoint when the NK1 receptor antagonist was added. So it still tells us that we still have a lot to do even in patients receiving oxaliplatin, which isn't considered highly emetogenic. So Dr. Hesketh in 2015 at ASCO presented data on rolapitant, which gives us some insight in a post hoc analysis looking at carboplatin. In that his post hoc analysis, he looked at patients that received rolapitant in combination with granisetron versus placebo and granisetron. When patients receiving carboplatin received rolapitant versus placebo, we saw about a 15% reduction in nausea and vomiting in the overall phase, which again, 15% is quite significant for the patient experience. Another area of interest is the use of the subcutaneous route. So we think traditionally of giving antiemetic prophylaxis either IV or orally, but recognizing that subcutaneous administration is usually safe and well tolerated, and the benefit is that you are avoiding these large Cmaxes when patients receive drug, and rather increasing area under the curve and exposure to a drug. So we have looked at studies comparing IV versus subcutaneous granisetron, showing that the area under the curve was improved by almost 25% through the sub-Q route, and receptor occupancy was about the same at 24 hours. So I think this is something for us to consider in moving forward. Is IV administration really the best way to give these drugs? And that we might actually improve the way we control nausea by giving it subcutaneously. Unfortunately, patients prefer not to get things subcutaneously. It might be a challenge in convincing patients that a sub-Q shot is the way to go, but again, might allow some flexibility in terms of where it's given, meaning either in the infusion center or at home.
There are a number of different trials that have been done recently demonstrating that olanzapine appears to work quite nicely for preventing nausea and vomiting associated with chemotherapy. Now, olanzapine is an antipsychotic drug. It's been around for quite a bit of time. It's available orally. It's actually quite cheap in terms of cost of the drug. Dr. Rudy Navari is the one who's been the main champion of looking at trials for olanzapine. I will share some information that he's presented recently. He's looked at olanzapine and compared it to patients receiving an NK1 receptor antagonist, aprepitant or fosaprepitant, plus palonosetron, plus dexamethasone, and demonstrated that patients who received the olanzapine had as good a complete response, and that means no vomiting for the first 5 days after getting chemotherapy, and no use of rescue medications. That's what the complete response is. So equivalent with patients who are receiving the olanzapine versus the more expensive NK1 receptor antagonist, both groups also receiving palonosetron and dexamethasone. The actual numbers of patients who had complete responses was a little bit higher in the patients receiving olanzapine versus the other regimen, but not statistically significantly so. The more interesting thing is that the amount of nausea in these trials was substantially less in patients who received olanzapine. And by nausea, the patients were asked on a scale of 0 to 10 on 5 days after they received chemotherapy whether they had any nausea. And to have a score of no nausea, you needed to put down a score of 0 for 5 subsequent days. The patients who received the NK1 receptor antagonist, 40% of them had no nausea during those days, and it was more like 70% in the patients who received olanzapine. And this was seen in 2 different trials. One trial was in patients who received highly metagenic chemotherapy, and the other trial was in patients who received highly metagenic chemotherapy along with radiation therapy for either esophageal or head and neck cancers. Those particular trials were not blinded, they were open label trials. In addition to these clinical trials, which look like olanzapine is similar to using NK1 receptor antagonists, there is an alliance clinical trial which was developed, approved by the NCI, has finished its accrual of patients. It randomized patients to receive olanzapine versus placebo, 4 days, 10 milligrams per day of olanzapine and an equally looking placebo, on top of standard antiemetic chemotherapy. The standard antiemetic regimen for both arms of the study was an NK1 receptor antagonist, aprepitant or fosaprepitant, physician choice, and a 5-HT3 receptor antagonist, which could have been palonosetron, granisetron, or ondansetron. It turned out that 24% of the time it was ondansetron, 75% of the time it was palonosetron, and 1% of the time it was granisetron. So the results of that study should be available in the near future.